for coming and for trying to learn a little bit about Lyme disease. And just a show of hands, does anybody not know what Lyme disease is? No, everyone, right? Everyone's affected by it or has family members. So my talk today, which is a mouthful, diagnosing and treating infections-induced autoimmune encephalitis in patients with persistent Lyme symptoms. So the first part of what I'm going to be talking about, which is actually defining infections-induced autoimmune encephalitis, which sounds very esoteric, but you'll be pros by the end of the hour. And that's really kind of what I want to highlight. I am a neurologist. I'm a clinician. So I see patients, both children and adults, in my practice. And I've been doing this for about 6 years, and I've been an attending physician for 6 to 7 years. And probably within the first month of being in private practice, I've got some very interesting patients who came in, and I really didn't know what was wrong with them. And over a course of a few months, have gotten a few more and have linked up with various Lyme literate physicians who started sending me patients who were not getting better with mainstream treatment. And over the last couple of years, really have started seeing particularly mainly Lyme patients in my practice and patients with Neuro Lyme. Maybe I can come down so I could read this better. I just want to be closer to you guys. So Neuro Lyme. So mainstream medicine talks about Neuro Lyme as being quite rare. So they say that it happens in about 10 to 15% of the population. And really, sorry, this thing. Oh, hold on 1 second. Here we go. So it's quite rare, according to the mainstream medical community, and really. Most patients will present with Lyme disease symptoms. In my opinion, all patients actually have Neuro Lyme. The severity of it obviously varies from patient to patient, and so early on in the disease process, the definition of patients who have headaches, fatigue, pain, these symptoms are neurologic symptoms. Later on in the disease process, you've heard all morning about the severe presentations of this condition, which I will be highlighting and talking in extreme detail later on in the talk. But obviously, a lot of the symptoms that you hear about and you may be experiencing yourself are neurologic. So the earlier you start treatment, the less chance of developing a permanent disability. And I think that's so important. And the fact that Dr. Spector was talking about how to treat it and Dr. Ligner was talking about diagnosis, that's so important because we need to really identify these patients early on. Hello? Can you guys hear me? So while he's getting the batteries, I'll try to speak a little louder. Is that okay? Can you hear me okay?
Yes.
Yeah? Okay. So the earlier you start treatment, the less chance of developing permanent disability. All right, so I was going to talk about what the agenda was. So again, redefining what Neuro Lyme is, defining what autoimmune neurology is, and then talking about the infections-induced autoimmune encephalitis, which I think that's really why you guys came to hear me, and types of symptoms that can be presenting in this condition, and diagnosing and treatment. I'll touch on that a little bit, and talking about prevention. Dr. Mark and I were just talking about how important prevention is, and when I talk to my colleagues, we all kind of think that, yeah, prevention is important, but I don't think we talk about that enough when we're in front of a patient because as Dr. Cameron said, there's so much to talk about when you have your 1-hour consultation. So Neuro Lyme, as I mentioned, it's 10 to 15% of cases according to mainstream medical community. And we usually talk about 10 to 15% in medicine when we think something's happening really rare. And when we think something's happening often, we say it's 85%. So as you see, Neuro Lyme is really falling into that rare category. And the way that mainstream medicine defines it is that you have a direct invasion of the bacteria into the nervous system. So that's really what happens with the Neuro Lyme patients. And some of the symptoms that they talk about, and the main ones that we talk about with this is lymphocytic meningitis. So it's inflammation and an invasion of the meninges. Cranial neuritis, which people talk about, Bell's palsy is the common one, but there's certainly other cranial neuropathies, and people suffer from extreme dizziness, which can also be a cranial neuropathy associated with Lyme disease and other ones. Mononeuropathy multiplex, which is a neurologic condition where you have involvement of a specific nerve, let's say one in your arm, one in your leg, kind of nerves that are not associated together. And painful radicular neuritis, which can always present with back pain and some neuropathies down the leg or your arm. So these are kind of the 4 main things that mainstream medicine thinks about when we talk about Neuro Lyme. So why do I want to redefine Neuro Lyme? Because in my clinical practice, what I think of as talking about Lyme disease is really the Lyme bacteria is associated with a number of co-infections. And again, that was touched upon earlier this morning by other speakers. Thank you. Hello? Oh, good. Okay. So it affects the nervous system. So I agree with the fact that it affects the nervous system directly, these infections. But there's also inflammation, as well as an evoked autoimmune phenomenon. And again, we'll talk in great detail over the next couple of slides about autoimmune disease. And Dr. Mark will talk a lot about the inflammatory process that happens. So I believe that the Lyme disease that we're talking about is really a trio. It's a collection of infections, it's inflammation, and it's an evoked immune response. Okay? And so that's why one magic pill doesn't cure every single patient, because if you've had this phenomenon happening for months or sometimes years, you're not going to be able to cure these things in a matter of 2 to 3 weeks of one antibiotic. So the process ultimately leads to an infections-induced autoimmune encephalitis in the case of central nervous system involvement. So autoimmune phenomenon causing neurologic symptoms. So the production of antineuronal antibodies. So in this slide, it's a little bit busy, but what I want to do is I really want to define the autoimmune phenomenon causing neurologic symptoms. And so these antineuronal antibodies that are produced and are triggered by the infections affect the central nervous system. And like I said earlier, it's causing an autoimmune encephalitis, meaning inflammation of the brain. So now not only the infection is directly causing an inflammation, but now your own immune response that's supposed to be killing off this infection is wreaking havoc on your central nervous system. And then you have also involvement of your peripheral nervous system, which is the neuropathies. A lot of times patients will develop demyelinating neuropathies, which are stemming from an immune response, as well as these autonomic nervous system issues that the speakers before me talked about as well. And so why does this happen? Well, the infection and the inflammation causes a break in the blood-brain barrier. So if let's say you had dinner and you didn't have a blood-brain barrier, what was going to happen, all of us would be encephalopathic, because some stuff after you eat dinner is important for you, you make energy from it, and other stuff you don't need, so you eliminate it. So all of this stuff that you don't need would get into your brain, and we wouldn't be able to function properly. You can't think properly, you can develop a headache, you can develop dizziness, you can pass out, and all of these things. And a lot of the stuff that Dr. Mark is going to talk about, the neuropsychiatric stuff, can happen as well. So we'll highlight, we will highlight on that. So the break in the blood-brain barrier, and then we have, it causes disruption of the regular brain matrix. So your brain really doesn't look the way it should. And people get really upset because when they have something wrong and they have a lot of severe symptoms, but their MRI of the brain looks fine, or the lumbar puncture looks okay, or their SPECT scan doesn't look too bad. And they come in and they say, well, everything looked normal. Well, why did Dr. Frid say at the Lyme conference that, you know, you have a disruption of your regular brain matrix? Well, because it's a microscopic disease, and you will not see it on an MRI. Some patients will have minor scarring or non-specific findings or a little abnormality on your LP, but it's not going to be a floored dysfunction that, you know, people are looking for. And what really happens is you have an increase in the inflammatory cells that you saw in Dr. Ligner's case. All of those little blue dots that he showed on that pathology should not be there. That's inflammation, okay? And then you have a disruption of the glial cells. And the glial cells are so important because they are actually helper cells of the neurons. Up until, I would say, 1980s and 90s, we really didn't understand the importance of glial cells. And the more intelligent the organism is, the more glial cells it has. And so Einstein's brain was studied, and there were three main differences that were noted from Einstein's brain to 5 normal controls of 5 males on autopsy. And one of the major differences was that Einstein had more glial cells in his brain. And so what happens with this condition is that you have a loss of these glial cells, and therefore patients present with complaints of cognitive impairment and say, oh, I'm just getting older, you know, I can't think straight, or I can't remember, like Dr. Spector was saying, I couldn't remember the speech that I was giving for an hour. So the, you know, glial cells and the inflammatory cells are really what changes the brain matrix in these autoimmune phenomenon. Oh, and this is a good one. He brought it up. So he was talking about idiopathic. So all of this, what I was talking about for the last 5 minutes, is thought to be idiopathic in mainstream medicine. So we don't know why it happens, okay? And what I'm trying to say is, consider this being an infectious or an inflammatory process. So not that we don't know. And the reason why it's so important to differentiate that is because the treatment is different, whether it's an idiopathic condition or it's an inflammatory condition. So what's new here? What's new is that we're talking about the, like I said, because this is so important, that we're talking about an infections-induced process, not an idiopathic process or a post-infectious process. Are there any clinicians in the room aside from the two that I see here? Okay. What type of medicine do you practice? Oh, so I'm glad that you're here. Okay. Thank you for coming. So what's important to note is that it's not a post-infectious process, or in many cases, it's not an idiopathic process, but it's an infections-induced process. It's more than one infection. And before I was doing this talk, maybe 6 or 12 months ago, I was just doing a little bit of research and have heard Dr. Bransfield speak a number of times and reviewed some of his literature. And what he says in this specific publication, which I really loved, and I think it points out what I'm trying to say here, is the fact that no self-perpetuating immune process without persistent infection has ever been scientifically proven. So this is important. Why? Because our patients, right, they don't have one insult and then they stay the same. That's perhaps idiopathic, right? But if a patient is continually getting worse, it's very possible that they have an active process that's going on that is driving their autoimmune phenomenon. So we talk about Lyme disease as being a great imitator. And I'm sure that you guys can mouth off a bunch of symptoms, and you're welcome to do so. I know that I haven't covered all of them here, but I do want to go over in detail about a lot of these, and primarily for the clinicians in the room, and also for patients with family members, because you live in the same environment, and you may not think that your little cousin or your older son, is exhibiting these symptoms, but or your grandmother, has some of these symptoms, and that it could be stemming from an infections-induced process. So I want to go over in detail about some of the symptomatology to perhaps trigger some thought about some people that you know or some patients that you see in your practice. So constitutional symptoms with chronic fatigue syndrome, headaches, insomnia. There are a couple of diagnoses on this slide that I personally don't believe exist. One of them being chronic fatigue syndrome, and one of them being fibromyalgia. I don't think that's a diagnosis, neither one of them. I think it's a symptom. So I think it's a symptom of something else that's going on with the person, and that we haven't identified the cause of it. And that's why we're just labeling it as a collection of symptoms. So chronic fatigue is one of them you've heard about, and I'm sure some of you have experienced how debilitating it can be. Headaches, that was probably the #1 thing that I was treating in my practice before I became a Lyme specialist. And I would say 70% of my practice was a headache practice, and 90% of my patients would get better within 1, maybe 2 medications that was recommended by American Academy of Neurology. And there were 10% of patients who wouldn't get better, no matter what you gave them. You put them in the hospital, they didn't get better. You gave them Botox, you gave them narcotics, you gave them IV medications, nothing helped. And then when you went back and saw, that when I pulled back their records, many of them actually told me that I've had Lyme disease 20 years ago, or I've been exposed, I went to Nantucket, and I had a tick bite 2 years ago, but I got my doxycycline for 10 days and I'm better now. And then they've developed these intractable headaches. So to me, when you're having a symptom, right, or migraines, tension headaches, or whatever that could have been for that specific patient, if most of your patients are getting better from a typical mainstream medical treatment, but a percentage of them aren't, then there may be an underlying cause that you need to keep looking for. Insomnia is a big one. Neurodevelopmental disorders. This is for children. So ADD and ADHD, actually I take it back. ADD and ADHD, explosion of ADD and ADHD in the adult population. This has not happened. Even in my training, which was about 10, 15 years ago, we really didn't talk about adult ADHD. Now it's all over the place. You get young adults, you get middle-aged adults coming in asking for stimulant medication. I actually have an adult patient he just comes to mind. He's in his mid-40s and on Wall Street, very successful guy, and his one and only symptom was that he couldn't concentrate, and he was on 3 different stimulants. We tested him for Lyme disease. He was positive, and I treated him. Within 3 months. He stopped taking all 3 of his ADHD medications, and he started reading books again that he couldn't read for 2 years. Autism spectrum disorders, a lot of the kids that come in to see me are on the spectrum. They come on the spectrum, they come off the spectrum. Is that autism? That's not a definition of autism. You know, it's a degenerative disease, it's a neurodevelopmental problem. You can't come on autism or come off autism spectrum. So clearly they have another underlying medical problem and an continuous insult on their immune system and their central nervous system that's causing this problem. I also always talk about looking for infectious etiologies and autoimmunity etiologies in developmentally delayed or autistic children who take a turn for the worse acutely. So that's something to look out for. Cognitive impairment, OCD type of behavior. I think Dr. Mark will talk about the acute onset OCD and type of behavior in PANS and Pandas, but this can be more subtle and kind of masked behind a slew of other symptoms and can be presenting in both children and adults. Learning disabilities, regressive behavior, which again is more prominent in children. It's easier to see it in children, but has happened in adults as well. For example, adult teenage kids who throw temper tantrums, or children who don't act appropriately, kind of clinging to their parents too much. Age inappropriate behavior is a red flag. And tics, meaning like motor tics, verbal, vocal tics. So tics are also present with Lyme symptoms. Neurodegenerative disorders. These are interesting to me because I'm actually not sure if if Lyme is mimicking these disorders, or is Lyme actually triggering these disorders. I don't know the answer to that, but in my patients that I see, if they're presenting with memory issues and Alzheimer's type symptoms, or ALS, MS, different type of dementia, Parkinson's disease, I've had more than a handful of patients with Parkinsonian symptoms, various ages, including children who present with Parkinsonian symptoms, being triggered and having tested positive for Lyme disease, and when you treat them, they get better. However, obviously, if you get children or patients who are presenting kind of later on in the disease process, you know, your grandma who has been living in a home for 3 years with Alzheimer's, I don't know if treating her for Lyme would actually revert back to the damage that was already done. I think very important on this specific list is MS, because MS is treated by lowering your immune system. And in a Lyme patient, that's not what you want to be doing. So you want to be improving their immune status, you want to be treating their infections, but you don't want to be lowering your immune system with Copaxone or Tecfidera or any of these type of medications. So it's very important to differentiate between MS and Lyme. The treatments are vastly different. So neuropsychiatric conditions, this is big. This is very big. And I forgot who from the morning speakers has brought up the point that H. pylori was actually thought to be a psychiatric diagnosis. But I think we're going back to that or we've never left the point that every time we don't know something in medicine, we call it psychiatric. Okay, so if you come in, all your regular blood tests are normal, that means it's anxiety or depression, or you need a vacation or something like that. So these disorders are, you know, super prominent in patients with anxiety, depression, mania, paranoia, psychosis thought disorders. So neuropsychiatric symptoms are extremely prevalent in Lyme patients and Neuro Lyme patients, and actually resolve when you treat the patient. There's no anxiety, there's no depression once you treat them. And then, of course, other symptoms that you've heard about today, autonomic nervous system dysfunction, which is extremely uncomfortable and very poorly understood. And there's only a handful of neurologists who actually treat this problem, which is usually treated symptomatically, and the drugs that we have for this are not that great. And because the patient has trouble explaining themselves as to what's happening, this then falls into this category. So the dizziness that I touched on upon, the fibromyalgia that I talked about before, various types of neuropathies, of course, seizures, tremors, visual disturbances. This is a big problem, especially in children, because they won't be able to communicate to you what is happening to them and why they don't like to read, why they're not succeeding. It could be because of these issues, and then a combination of visual disturbance where the eyes are jumping and they can't read and they can't concentrate. So it's not just a cognitive issue, it's also an anatomical problem where if their eyes constantly do this, right, they're jumping like this, they're not going to be able to scan when they read, and it'll take them 20 minutes to read a page. And weakness, of course. And I'm sure I'm missing some things, but you get the idea that this is really a big kind of diagnostic dilemma, because people can present with one of these symptoms, or they can present with a collection of these symptoms. So why does Lyme develop into a chronic illness? It develops into a chronic illness very simply because the symptoms are very subtle in many patients, and it's very easy to excuse these symptoms. It's easy to excuse because, oh, I have insomnia, it's because I have a new baby. I'm anxious because I just got this new project at work, and my memory is not good because I'm not sleeping well, and various others, and I have aches and pains because I was training for a marathon. I actually spoke to a patient this week who said that her symptoms presented right after the birth of her third child, and for many months she was diagnosed as postpartum depression. So it could be very vague, and it can happen very subtly until months or years from now, you look back and you realize that you're not the person that you were 2-3 years ago, and you have this collection of symptoms. So I think a red flag is when you start going to various doctors and you get Tylenol here, an antidepressant there, a sleeping pill somewhere else. That would be a red flag that something may be going on. The next point is testing is inaccurate. And we all know this, and we've touched on this earlier today. And the problem is that we're having this two-tier approach, which means that you have to test, your blood test has to be abnormal through 2 types of techniques, and you have to have the proper number of bands, which the immune system may not be developing as quickly as the laboratory would like it to. And actually, I've wrote a newsletter on this, which you can find on my webpage, elenafridmd.com, where you to help to interpret your blood test, because the ILADS organization actually talks about how there are certain bands in Lyme that are Lyme specific, and other ones that are less specific. So even if you test positive for, let's say, 1 or 2 bands, if they're Lyme specific, that's significant. And so it's important to also ask your doctor to not only run the ELISA test, which is the preliminary screening test, but also run the Western blot on every time that you get your blood drawn, to see if your antibodies are changing and how many antibodies, if any, are positive. And also, I think it's important to mention here, I'm not touching on this too much during this talk, but I think it's very important to note that the co-infections are extremely important in these cases, and typically patients don't have just one infection. I don't think I've seen, I see pretty complicated cases on a daily basis, and I don't think I've seen one patient in my practice who's had just Lyme disease. All the patients that I've seen have had a collection of infections, anywhere from 2 to 5, sometimes more, and it really depends on the basically integrity of their immune system and really the rates of re-exposure that they've had. And I'll touch on that a little bit more later in the talk. And then the treatment is misunderstood. And it's misunderstood because, A, we're under-treating patients. Let me see what's next. Okay. So if we're under-treating patients in the sense of, I think, 2 to 3 weeks of antibiotics is inaccurate for people. And it's also very important to note that the co-infections need to be treated in conjunction with the Lyme bacteria. So you can't treat, in my practice, I don't treat Lyme, and then I'll treat the Bartonella, and then I'll treat the Babesia. I treat all of them at the same time. Treatment for Lyme and Neuro Lyme. So identifying, you're going to hear this probably 3 or 4 more times, because I don't think it's important. Anyway, so you're identifying all the offending agents and treating them all at the same time. And then once that happens, you assess for autoimmune phenomenon and add, you don't replace, you continue to treat their infections, and then you add an immune modulating therapy if symptoms persist for more than 6 months despite proper treatment. And actually, I've been looking at Tessa Gardner's work. I don't know if any of you know who she is. She is a pediatric infectious disease specialist who's actually published in a prominent textbook, medical textbook. However, I think that chapter was taken out since, I think it was published in the 1990s and then again in 2000. Where she talks about the duration of treatment for Neuro Lyme patients. So duration of treatment for Neuro Lyme patients. Duration of treatment for Neuro Lyme patients should be 1 to 3 years. Okay. So if a patient doesn't get better within about 6 months, okay, then we check them for this autoimmune process that I talked about. And this specific slide highlights this autoimmune encephalitis that I was talking to you about, that presents with your neuropsychiatric treatment symptoms, that presents with your MS or Alzheimer's or ALS or these vague fibromyalgia and learning disability issues and autism type of things. So you check their MRI of the head, and don't get upset if it's negative, but it can show slight abnormalities like scar tissue, these white matter changes that are not specific. Well, they're not specific for whom? You know, for Michael Phelps, who won his, 30th gold medal, okay, they're not specific. For a patient who's 18 and in a wheelchair and can't go to college, maybe they're specific. So an EEG, which looks at brainwave function, brain SPECT or brain PET scan. Okay, so that's important to look at perfusion, which is often abnormal. And I specifically use Columbia, Dr. Fallon's clinic, because they've done some work and they do a good job in interpreting the SPECT scans. And then we do blood work. We check the blood work through Mayo Clinic with paraneoplastic panel, as well as specifically checking for autoimmune encephalitis panel with potassium channel receptor antibodies, NMDA receptor antibodies, GAT65, Casper2 antibody, glutamate receptor antibodies, S100B, and we don't know all of these antibodies. I got a call last week, a young girl that I'm treating, 16 years old, who's having a lot of neuropsychiatric symptoms and cannot really keep up with school. And the Mayo Clinic physician called me and said, well, what's wrong with her? I gave the history, the clinical presentation, and he said, you know what, I think this is a new anti-neuronal antibody because I haven't seen this before, but it does look abnormal. So we're still discovering these things every day. You can do a lumbar puncture. A lot of the times I will run these anti-neuronal antibodies not just in blood work, but also in the lumbar puncture. And you would do a neurocognitive assessment. That's actually quite helpful in diagnosing autoimmune encephalitis because in a lot of patients, they will have a drop in IQ. And so neurocognitive assessment becomes really important. And brain biopsy. I've never done brain biopsy, and I'm not planning to do brain biopsy on any one of my patients. However, this work was done about 10, 15 years ago when we started talking about autoimmune encephalitis in neurology. It started in Japan and then was done in the United States as well. And these are the people, thanks to them, thanks to the physicians and to the patients for allowing us to do this, that we noted that this is a microscopic problem and that they have subtle lymphocyte infiltration and a loss of glial cell. And because of that, we started looking at these anti-neuronal antibodies. So now most of my patients will get an MRI, an EEG, a brain spec, blood work, maybe an LP if we don't get any answers here, and the neurocognitive assessment, so we don't need to go the invasive route. There's also the Cunningham panel, which looks for these specific anti-neuronal antibodies that I didn't touch on the previous slide. Mainly, these anti-neuronal antibodies are done in Mayo Clinic. They have patented most of this, and so no matter where you send over the blood, where you get your blood drawn, it usually gets sent over to Mayo Clinic. And this is a different laboratory, Cunningham panel, which works a lot with PANS and Pandas patients. In my opinion, and I believe that's the opinion of most physicians, PANS and Pandas really falls under the autoimmune encephalitis. So you have autoimmune encephalitis and Pandas falls under there. So everything that I'm talking to you about today applies to PANS and Pandas. PANS and Pandas is really just thought to be from strep infections. However, it can also be seen in patients who have Lyme disease, Mycoplasma pneumoniae, and other infections. So what's the treatment of that type of patient? So let's say you've had a patient who had all of these infections. You started treating them. They've been treated for about 6 months, and they're not budging. Nothing's better. You start assessing them for autoimmune encephalitis, and they tested positive because their presentation is very neurocognitive, neuropsychiatric, or neurodegenerative. And so you continue treating their infectious causes. I always explain that as the infection is driving the autoimmune process and the inflammation. And so if you're just treating the autoimmune process and the infection is still there, you can treat the autoimmune process until the cows come home, but the driving force continues to be there. And therefore, you need to continue treating the infection, and then you treat the autoimmune process with it as well. And that way you subside of what's going on, all this inflammation and the infection that's going on in the patient. Usually in my practice, I will add IVIG in immune modulating doses. This is very, very important. So like if I told you, if you have a fever, just take Tylenol. And then you told me, oh, I took Tylenol. And I say, well, how much did you take? You said 50 milligrams, 50. But it didn't work for me. Where in order to get your temperature down, you really need to take 650 milligrams or 1,000 milligrams. So this is what happens to a lot of my patients, where they come and they take a fraction of the IVIG because it's very cost prohibitive. Okay, so 1 gram of IVIG costs, and this is on a discounted rate of it's $100 or more. And so since it's a weight-based product, a lot of patients are getting IVIG, which costs $10,000 a month at this dose, maybe more depending on your weight, right? But it doesn't work in smaller doses. And if you're giving it in smaller doses, you're really just replacing your immune system instead of modulating it. And that's why giving it at higher doses, which we just talked about, giving it at higher doses over 2 days back-to-back monthly, instead of giving it at smaller doses on a more frequent basis, is more effective. And then improvement, again, it's not a magic drug, right? You're trying to modulate or kickstart your immune system to do something different than what it's already doing. So what you want to see, improvement is measured in 9 treatments, which is about 9 months. So 7 to 9 months, you want to see some improvement. And most patients are in treatment for about 2 years on a monthly basis. I actually want to go back here and talk about, just in general, about the duration of treatment. In neurology in general, a lot of because of brain plasticity, like you don't measure things over a day or 10 days. A lot of the studies that we do, like let's say stroke, if you give somebody TPA because they've had a stroke, these studies are measured, the outcomes are measured, how is the patient doing 3 to 6 months out from getting that medication. If you do brain surgery on somebody, you measure their outcomes 6 to 12 months of how, if you reassess them at 12 months after surgery, and you expect, okay, that's how the patient's going to be. You're not assessing them 1 or 2 weeks after they've had brain surgery. Similarly here, I just told you about what an insult on the nervous system that autoimmune encephalitis and these infections can have. And I told you that the treatment is, on average, 1 to 3 years, which is appropriate for, to talk about if we look at other neurologic conditions, 1 to 3 years is an appropriate outcome and expectation to be treating something that's a continuous insult on your nervous system. So this is what patients always ask, right? Are your symptoms reversible? Especially if you're on that list with, in a wheelchair or not going to school or can't work, have severe pain, weakness. It depends. It depends if the symptoms are reversible. Of course, I'm always hopeful that, we can cure every single patient, but history taking is important in order to find out, the patients who come to me always want to come at their worst because they want to show, this is how bad I am. I actually like to see them at their best, because if you're having good days or good hours, like you feel close to normal or significantly better, it tells me that there's a reversibility to the process. So history taking is very important. Clinical exam, do patients have severe disability that don't get better? Do they have spastic gait? Do they have blindness? Hearing loss, depends on, so that's important. Imaging studies. Do they have, like I think it was Dr. Ligner who talked about atrophy of the cerebellum. Do they have significant findings on an MRI that may not be reversible? So in that case, we talk about making them better from the standpoint of halting their progression of the disease process, instead of saying that, okay, you'll be, back doing cartwheels in 6 months. And again, type and duration of treatment that they've had. So a lot of the times, if I assess patients and they may have not been on the right treatment, where they've been, I have a patient who's been on a ceftriaxone for 5 years, every single day for 5 years. And she is walking with a walker. She's 35 years old. And so in my opinion, when we assessed her, she had Bartonella, Babesia, and Lyme. So ceftriaxone, as you saw from Dr. Cameron's talk, is not going to address all of those issues. So it really depends on what was the treatment that she was on. Oh, this is what I want to switch over to prevention. This is actually a product that I've developed. And I think it's very important to talk about prevention because I don't think that I've seen a patient in my practice who've had one tick bite. I think that these patients have a continuous re-exposure on their immune system and continuous insult on their immune system, whether it is through infections, whether it's through tick bites, whether it's through other insects like spider bites or fleas or something like that. This type of re-exposure is very common. A lot of times the patients who have devastating neurologic symptoms have recurrent problems over many, many years. And that's why I think it's so important, guys, it's so important to protect your yard, because I have patients who continue to do exactly the same thing that they've been doing, working in their yard, going outside without protecting themselves. So you have to protect your yard. You have to know that your pets can bring this into your home, and they need to be protected as well. And you need to protect yourself. And I advocate that you and your children should be wearing permethrin treated clothing when you're going outside. I'm not saying that you need to treat your tuxedo or your ball gown in permethrin, but if you're outside, if you're outdoors, I think that you should have you and your children treated. And I joke about it on my social media, which is this, that we're all one tick bite away from a psychiatric diagnosis. So, I'm on Instagram and I'm on Facebook and I'm trying to raise awareness for Lyme disease. I would say 90% of everything I post is educational on Lyme disease. And I'm also, I have a YouTube channel where it's not too long. The videos are quite short. Just also bringing awareness on some things. I think there was ADHD somewhere here. Can Lyme disease be cured? Things like that. So you can go on YouTube and follow me there. And that's it.